Hey guys, sorry I just got off of work, so I am doing this kind of right before I'm about to go to clinicals, so yeah, bear with me. So I'm doing my presentation over inflammatory bowel disease. Here is my table of contents that includes all of the things that we'll be going over today. And this first section is the pathophysiology, including common signs and symptoms of IBD. So, inflammatory bowel disease, or IBD, is comprised of two major disorders, ulcerative colitis and Crohn's disease, or as many people refer to it, Crohn's disease. Ulcerative colitis mainly affects just the colon and sometimes the rectum and is characterized by inflammation that's limited to just the mucosal layer of the colon, whereas in Crohn's disease, it can involve any component of the GI tract from the mouth to the anus, and it's characterized by transmural inflammation that often presents as skip lesions, and this will be something that is important to remember for a few slides from now. Transmural, though, is meaning like across the wall of an organ or structure. So in essence, this means inflammation that affects all layers of a tissue or organ wall rather than just the surface or inner lining, such as the first one. So one way that I like to think of it is to help me remember which one is which is when you think of ulcerative colitis, just think of colon for colitis. So ulcerative colitis only affects the colon, whereas Crohn's disease affects the entire GI tract. So globally, IBD accounted for over 4.9 million cases in the year 2019. The total annual healthcare costs associated with IBD are also estimated to be about $8.5 billion, and its prevalence in the U.S. has been gradually increasing over the last decade, with the typical age of onset being between the ages of 15 to 29, and the highest prevalence being in Caucasian individuals. On this slide are typical features that are useful in helping you to distinguish between classic ulcerative colitis and Crohn's disease. In general, the most common symptoms that you'll see in a patient suffering with IBD overall includes abdominal pain, diarrhea, fatigue, gas and bloating, rectal bleeding or bloody stools, and unintended weight loss. Some things to note real quick before we really get into each of these are that some patients with ulcerative colitis can also have mild upper GI tract inflammation, just like some of these symptoms can be seen in the opposite disease. For example, hematochezia, or blood in the stool, can be found in both at times. It's just more common in one versus the other. So ulcerative colitis, again, it's localized to the colon. Hematochezia is a little bit more common in this one. Mucus or pus in the stool, anti-neutrophil cytoplasmic antibodies, and occasional non-classic features including gastritis and mild perianal disease. Crohn's disease, on the other hand, again, affects the entire GI tract, including the small bowel, and sometimes may have a right lower quadrant mass, small bowel or colonic obstruction, fistulas, and perianal disease, sorry, I'm going to say this really messed up, Saccharomyces cerevisiae antibodies. Transmural inflammation, again, skip lesions, cobblestone appearance, and granulomas on biopsy. So again, some of those really, really important signs and symptoms that I cannot stress enough because they are super important for you to know. So classification of one or the other is usually accomplished with a combination of endoscopy and imaging of the small bowel, which we will speak to a little later on in this presentation. And then if after a full workup is done and the provider is still unable to differentiate between the two, it is provisionally termed IBD unclassified or IBDU, formerly known as indeterminate colitis. I've also made some of the key differentiations. Sorry, I just got off of work, guys. In this slide red, as I have noticed that these are often keywords used in test questions regarding IBD. So that's probably a pretty good tip to know for boards if you get nothing else out of this presentation today. In particularly, they like to use the words transmural and skip lesions, so I've noticed. So this is why these are important to know, like I mentioned a few slides back. Children with IBD. The most useful indicators of possible IBD in a child with abdominal pain are diarrhea, growth failure, pubertal delay, weight loss, rectal bleeding, pallor, fatigue, perianal skin tags, perianal fistulae or abscesses, a palpable abdominal mass, and a family history of IBD. These symptoms may point to IBD versus functional abdominal pain that's very common in children and typically occurs as a result of constipation. Also, side note, the perianal skin tags that I just mentioned too, sometimes those are like misdiagnosed as hemorrhoids. So just FYI. So that's another thing to be on the lookout for if you suspect that the patient might have IBD. And then these are just some interesting things that I found when I was researching IBD. Side note, I could have probably have made like a comparison table to kind of better like visualize these things, but I didn't want to dwell too much on all of these. They're just kind of like fun facts that I found throughout that may or may not be helpful in the future. So gender, with Crohn's disease, there is a slight female predominance, which also suggests that hormonal factors might play a role in disease expression, whereas in contrast, there might be a slight male predominance in ulcerative colitis. Smoking is not actually a risk factor for developing ulcerative colitis, with some even claiming that it might be a protective factor, potentially lowering the risk of developing the disease, whereas it is in Crohn's disease. Physical activity has been associated with a decrease in the risk of Crohn's disease, but not in ulcerative colitis. Dietary factors, high fiber intake has been associated with a decreased risk for Crohn's disease, but not for ulcerative colitis. Vitamin D intake is inversely associated with risk of Crohn's disease, with vitamin D deficiency being common among all patients living with IBD, and dietary emulsifiers and additives appear to play a role in changes in the microbiome and subsequent risk or lack thereof for IBD. Sleep duration. Some studies have shown that sleep deprivation has been associated with an increased risk of ulcerative colitis and disease flares in patients with IBD in general, hence why I'm probably going to get it when I'm older. JK. Women who report a sleep duration, though, of less than 6 hours or more than 9 hours per day had a higher risk for developing ulcerative colitis compared with women who slept an average of 7 to 8 hours per day. In contrast, sleep duration did not modify the risk of Crohn's disease in these studies. Oral contraceptives and hormone replacement therapy. Oral contraceptive use was associated with a higher risk of both ulcerative colitis and Crohn's disease compared to those not taking those. And in a study of postmenopausal women on hormone replacement therapy, it showed that its use was associated with an increased risk of ulcerative colitis, but not Crohn's disease. And then an appendectomy. Some studies have suggested that the risk of Crohn's disease is increased after an appendectomy. Sorry, words are hard. Whereas some data suggests that having an appendectomy may lower the risk of developing ulcerative colitis, while the mechanism of this protective effect is actually unknown, though. So, FYI. And then last but not least, pollutants. So there's emerging evidence that suggests that environmental pollutants may also be associated with an increased risk of developing IBD overall. All of that said, each of these, along with several other things, may be considered to be risk or protective factors associated with IBD. These are just the ones that I personally found really interesting and unique. So, diagnosis, which is our next section, including clinical labs and imaging. So the diagnostic evaluation of IBD involves 5 steps. The first is clinical suspicion of the illness based on clinical symptoms, examination, and screening laboratory data. The second is exclusion of other illnesses that have a similar presentation. The third is differentiation between ulcerative colitis and Crohn's disease. Fourth, localization of the region of the disease. And fifth is identification of extraintestinal manifestations, such as sclerosing cholangitis. The last 3 of these steps is generally going to be performed by a specialist, though, in gastroenterology. So we're really going to focus on the first 2. Other extraintestinal manifestations, though, might also include oral ulcerations or aphthous stomatitis, clubbing, a rash, specifically erythema nodosum or pyoderma gangrenosum, eye inflammation or uveitis, jaundice and or hepatomegaly, and even arthritis. I put the slide here that says my physical appearance does not reflect how sick I feel, because oftentimes IBD is a disease that is not always outwardly apparent. So it's important that as providers, we are keeping this in mind when evaluating and treating these patients. So you guys can kind of read over this slide while I talk, but these are the specific tests used in the evaluation, treatment, and monitoring of patients living with IBD. With the blood tests, it's also important to note that these levels will not be abnormal in all patients presenting with IBD, and patients with more severe disease are more likely to have abnormal lab values, particularly in ESR levels. Thus, endoscopic and radiographic evaluation is sometimes appropriate in some patients in whom there is a strong clinical suspicion of IBD, even if initial blood tests are normal. Some other modalities that may be used to diagnose IBD also include a video capsule endoscopy and ultrasonography too. Just forgot to throw those on there. And then the third is treatment. Really quick before we really kind of start to dive into this, I just wanted to note that there are several factors that may be taken into or must be taken into consideration when deciding on treatment for both of these. Including coexisting inflammatory conditions such as inflammatory arthritis, psoriasis, and MS, for example, patient preferences, patient characteristics, including their age and sex, risk of adverse events such as infection and malignancy, other medications currently being used, prior therapies that were used for treatment of these conditions, accessibility to an infusion center, patient compliance, and coverage of medication costs by payers. Because multiple factors inform the decision to begin a patient on a specific regimen, the choice is individualized and decision-making should be shared with the patient. So this selection process kind of results in the treatment variability among patients with IBD, subsequently creating an individualized treatment plan for each patient that presents. I also just wanted to note that depending on the pharmacological therapy that's prescribed, additional tests may be needed to initiate and or maintain patients on these regimens, each of which you as the provider should definitely make yourself aware of prior to prescribing any of them. For example, some of these medications may require testing of liver enzymes, a lipid profile, and other lab studies such as a Hep B surface antigen or an interferon gamma release assay, just to name a few. So Crohn's disease. So these classes of medications are kind of like the mainstay for treatment of Crohn's. You'll notice in the next few slides that it's going to be pretty similar to the treatment for ulcerative colitis, but we'll talk about that a little bit more here in a bit. So it's important to know that the choice of therapy, again, also varies depending upon the anatomic location of the disease, the severity of the disease, and whether the treatment goal is to induce remission or maintain remission. But these are going to be the main medical therapies that are used for Crohn's disease. Sorry, I just don't want to dwell super heavily on this. I made a lot of notes over all of these different classes. So yeah, we're just gonna say that these are your main ones though that you kind of want to focus on. And then here in this next slide, I did include kind of what UpToDate says is how you should go about prescribing different glucocorticoids, for example, for this patient population. And then ulcerative colitis. So as you can see here, again, there are a lot of similarities between the treatment of Crohn's disease versus ulcerative colitis. And then some of these are going to be kind of more based on patient preference too. It's going to be strongly associated with that. But for this one too, the topical mesalamine via rectal suppository or through the use of an enema is actually going to be your first line treatment for mild disease with symptomatic improvement expected within a week of initiation. So FYI on that. And then yeah, so those are going to kind of be your main ones. A lot of them are going to be very similar to the same ones that you will prescribe in Crohn. Here is the approach that UpToDate provides for this one. So I thought that would also be useful for you guys. And then kind of just like asthma and other things, they have this step up treatment for IBD that I thought was a useful little pictographic thing to include here that kind of shows like where we want to start and like kind of all the way up to biologics. And then managing symptoms of IBD. So these are going to be like symptom-based therapy, so diarrhea, loperamide, abdominal pain, antispasmodics, SSRIs, gabapentin, constipation, Miralax, bloating, different types of FODMAP diets. Interestingly, diaphragmatic breathing exercises can help with that. Fecal incontinence would be like pelvic floor physiotherapy, which is also interesting, and I would suggest looking further into if I were you guys, because very interesting stuff there. And then cognitive behavioral therapy, gut-directed hypnotherapy, and mindfulness therapy. Well, don't mind the little notifications on the bottom, it's fine. And then surgical interventions. So although advances in medical therapy have coincided with lower rates of surgical resection in patients with CD in particular, surgical intervention is still often required in the setting of bowel obstruction, abscesses or fistulas, or refractory disease. Surgery does not cure CD, and although clinical remission is oftentimes achieved using these interventions, most patients will still eventually relapse, with many requiring subsequent surgeries, unfortunately. And then in UC, indications for surgery may be required when a patient fails medical therapy or when a serious complication arises. Emergent surgery is indicated in patients with a colonic perforation, a life-threatening GI bleed, or a toxic megacolon. Urgent surgery is generally indicated in patients with acute fulminant colitis, and that's refractory to medical therapy. And then lastly, elective surgery is indicated for patients with persistent symptoms despite having received the best medical management they could attain, and for those with an increased cancer risk. And then this next one, this last section here is going to go over pertinent information, including patient education and follow-up. Again, words are hard this morning. So learn to rest, not quit. I kind of want to start this section off with this little inspirational quote that I found that I thought could apply to those suffering with inflammatory bowel disease. I feel like all providers should instill confidence for the future and optimism in their visits with this patient population, and encourage sufferers to continue fighting forward while not allowing their disease to get the best of them. Just, focus on some mental health stuff with them too, because I'd assume that this is not a very easy thing to deal with. Make sure, offer them the help that they need if they need it. And then health maintenance. So lab monitoring, you're going to want to do a CBC every 6 to 12 months for patients with IBD. For those patients found to have anemia or those with a low MCV, we also check ferritin, transferrin saturation, and a CRP, as a CRP is important in the interpretation of the ferritin level, as ferritin is an acute phase reactant. Other potential causes of anemia in patients with IBD should also be explored, including anemia of chronic disease, vitamin B12 deficiency, folic acid deficiency, or drug-induced anemia, such as in patients being treated with sulfasalazine or thiopurines. That was shown in those last few slides regarding treatment. And then for patients also on the 5 ASA agents, we need to measure their serum creatinine at 6 weeks, 3 months, 6 months, and 12 months after the initiation of therapy, and then annually thereafter. And for patients started on different thiopurines, lab monitoring should consist of looking at their hemoglobin, white blood cell count, platelet count, liver function tests, including a serum aminotransferase, and a total bilirubin, with all of these being performed at short intervals, for example, weekly or every other week, until a maintenance dose is finally reached. So lab testing is continued periodically then for the rest of the duration of the therapy. And then other things, obviously, again, we want to watch out for the anxiety, depression, like I spoke to in that last slide, and offer them regular screening and appropriate help and resources. With disease activity, this is where you're going to want to use a stool marker, calprotectin, all of that might be utilized. Specifically, in a systematic review of several IBD studies, patients in remission showed that a greater than or equal to 2 elevated calprotectin measurements corresponds to a 53 to 83% probability of relapse within the following 2 to 3 months. So just a little FYI on that. Vaccinations are going to be super important in regards to those patients on immunosuppressive therapy or the biologic therapies. So you definitely want to go over this with patients, preferably before they're started on these therapies, because you kind of want to see where they're at on their vaccinations. If patients are receiving these things, you want to recommend to them that they receive the non-live vaccinations of both flu and the or pneumonia vaccines. And then if they are still needing caught up on different vaccines, definitely want to make sure that they're still getting like non-live vaccines. So like with measles, for example, that should ideally be administered greater than or at least 4 weeks prior to the start of immunosuppressive therapy versus while on. So definitely review these things before prescribing patients all of these things. Osteoporosis, so due to the increased risk for bone loss in patients living with IBD long-term, we want to make sure that we're screening for this using bone mineral density testing. So we should be doing that at the time of diagnosis and then periodically thereafter in all patients with IBD who meet at least one of the following criteria: postmenopausal, ongoing glucocorticoid treatment, cumulative prior use of glucocorticoids exceeding at least 3 months, a personal history of low trauma fractures, or those who are aged over 60 years. On that note, patients who are on glucocorticoids at any dose with an anticipated duration of greater than or equal to 3 months should maintain a total daily calcium intake of at least 1,200 milligrams per day and a vitamin D intake of 800 international units per day through either diet and or supplements. So this is something that you should definitely also be educating your patients on. And then cancer screening. So you want to specifically look for colorectal cancer, cervical cancer, and skin cancer. With the cervical cancer, it needs to be performed for all women with IBD who are on immunosuppressive therapy. Specifically, patients with IBD are at an increased risk for colorectal cancer. So they should definitely do the CRC screening with colonoscopy based on the extent and duration of their disease. It's also important that clinicians emphasize the importance of cervical cancer screening to women living with IBD, specifically who are on the immunosuppressive therapy, again, as compliance with this type of cancer screening tends to be low within this patient population. So just a little side note there. And all IBD patients who have taken or are currently taking or who are planning to start taking immunomodulators or biologic therapy should also undergo annual skin examination by a dermatologist, as melanoma and non-melanoma skin malignancies are commonly associated with these therapies used in IBD. Additionally, non-melanoma skin cancer is associated with past or current use of 6-mercaptopurine or as I can never say this, azathioprine. There we go. So yeah, the thiopurines. Thiopurines. That word. And then educating patients with IBD. So a few other helpful tips that you as the provider may offer to your patients to help them in symptom management may include things like dietary changes. There are lots of different diets that you can recommend to patients. Again, like that FODMAP diet that we mentioned before, Mediterranean diets, or elimination diets. Generally recommended, or overall, it's not really recommended that patients need to follow like elimination diets, but you could suggest this to patients and have them keep like a food diary so that they can use that to kind of help them to identify triggers without necessarily needing to eliminate these foods either, just to be like cautious and weary, like, hey, we know that this specific food might cause these symptoms later on, you know? So just a good little tip to give to them. And then other diets also too that could be recommended might include like low carb diet, plant-based diets, stuff like that. Yeah, and then regardless if the patient's having issues with constipation, have them increase their fluid and fiber intake, avoid lactose if they're lactose intolerant, eat smaller meals more often, and do not skip meals, preferably. And then keep, that diary of what you eat and any symptoms that you have as a result of the foods that you eat, because this might, again, help you figure out which foods make your symptoms better or worse. While there was some very mild research on the protective factors associated with smoking tobacco products, it should still definitely be advised to patients that they should quit smoking if they smoke, as most often smoking also will make symptoms worse. And then even getting gentle forms of physical activity can help, such as walking, even just a few days a week. All of that's really good for our health, obviously. And then with these patients, they want to avoid those NSAIDs, so ibuprofen and naproxen. Although depending on the specific circumstances, some patients can still take NSAIDs. They're just recommended to be taken at the lowest possible dose available and only when absolutely necessary if there were contraindications to other forms of, pain management. And then other things, probiotics, obviously they're going to help out with that gut microbiome. And then preventative health maintenance and making sure that we're doing those follow-up exams, making sure we're getting those follow-up labs in, following up with your patient, following them through, making sure that things are going well, all of the things. And then remember, every day may not be a good day, but there is something good in every day. So, by someone famous. Here are my references. And final slide. So if you guys have any questions or anything, let me know. I am available via, phone call, text, preferably text, and email. So if you guys have any questions, definitely feel free to reach out. Hopefully you guys learned lots from this presentation. Apologies again that I am kind of rushing through this a little bit right before clinicals. Just trying to get it done so I can get it turned in today. And yeah, so anyways, have a good day, guys. All right, bye.